in the occurrence and the prevalence of these diseases, such as the diabetes mellitus type 2, obesity, hypertension, and heart diseases, and also chronic obstructive pulmonary disease, or COPD. So I would love to thank IPSF EMRO for accepting our invitation to be collaborating with us today. And also I would love to acknowledge the efforts of LBSA to be with us today in this amazing webinar. Also, I would love to give love to my university, Future University in Egypt, for partnering with us today in this great webinar, and also a great acknowledgement to Dr. Nuran Omar and also Dr. Yasser for accepting our invitation to be speakers with us today. And also, I'm very beloved to our speaker, Dr. Hagar Awad, for accepting our invitation. So I would love to introduce Mr. Omar Adel. He's the chairperson or he's the regional project coordinator as in IPSFM. So the floor is yours, Omar.
Thank you, Ahmed. So hello, everyone. Hope you're all doing well. This is Omar Adel, the IPSF EMRO Regional Project Officer, and I would like to welcome you to this important event that mainly focuses on lifestyle changes in chronic diseases. So speaking on IPSF, we are a non-profitable, non-political member organization, and we have regional and global working groups. However, we as IPSF EMRO working group, we are the one responsible for the whole EMRO region, and we have different member organizations such as QFIS and actually LPSA who are with us today. So our responsibilities, we actually have many responsibilities, including the one we are doing today, which is organizing events. I believe without further ado, let's get into the event. But before that, I would like to thank the speakers for accepting our invitations and all the members that worked hard to provide for this event. And inshallah, it will be a fruitful event. And without further ado, I would like to leave the floor to, I believe, Ms. Jana from LPSA.
So hi everyone, thank you all for being with us today. Allow me first to introduce myself. I'm Jana Baidoun, the public health chairperson in LPSA. So to have an overview هيك شوي about LPSA, so the Lebanese Pharmacy Students Association, known as LPSA, is the only non-governmental, non-political and non-religious, also non-profitable organization serving as the national collective voice of students and recent graduates in Lebanon. So our mission is to unite pharmacy students, to praise the pharmacy profession, to promote the pharmacy education, as well as to raise the public health awareness. Plus, our vision is to unite all members, to equip them to the professional life, to increase the members' involvement in the global health, also to strengthen the commitment to healthcare. I believe that this topic is very crucial and we should shed the light on it. Thank you again, IVPN and IPSF EMRO, for this collaboration together, and I hope you guys enjoy this webinar.
So back, I will introduce our moderator today, Mrs. Roba. You can go. The floor is yours.
Hello, everyone, and welcome to our webinar titled Choose Health, Empowering Lifestyle for Better Disease Prevention and Management. My name is Ruba Mansour. I'm a part of the IVPN Student Public Health Committee, and I'll be the moderator for this webinar. Before we start this webinar, I'd like to let you know that this webinar will be recorded and you can access the recording in the IVPN Student Network website. And please make sure to fill the attendance form to receive the certificate. And at the end of the session, if you have any questions for our speaker, please feel free to type them in the Q&A section in the chat box. We also encourage you to become part of the IVPN network by joining any of our listservs via the IVPN network website. Welcome to our webinar session, Choose Health, Empowering Lifestyle for Better Disease Prevention and Management. In today's fast-paced world, making informed decisions about our health is more critical than ever. This webinar aims to provide you with knowledge and tools necessary to take charge of your well-being. We'll explore practical strategies for preventing disease through healthy lifestyles, choices, and discuss effective management techniques for existing conditions. By empowering you with actionable insights, we hope to inspire positive change that lead to a healthier, more fulfilling life. Thank you for joining us today on this journey towards better health. Now, I'd like to introduce our first speaker for today's webinar, Dr. Yasser Omar Musaad. Dr. Yasser Omar Musaad is a certified international professional trainer from Missouri University and an expert with over 30 years of experience in hospital pharmacy. He is currently a lecturer at Fletcher University in Egypt. Dr. Musaad holds a doctorate in pharmacology and toxicology from Priory University and has conducted research at the Royal College in London. In this webinar, he will be discussing and revealing the role of lifestyle in type 2 diabetes, obesity, and their consequences. Over to you, Dr. Musaad.
Good evening, everybody. Thank you, Ruba Mansour, for this intro. And many thanks for the IVPN student organization and LPSA and the IPSA Federation for their invitation. And I will tonight will talk about the session unveiling the role of lifestyle in type 2 diabetes, obesity, and their consequences. First of all, there is an introduction about the diabetes. What is diabetes? Diabetes is a chronic disease when the pancreas does not produce sufficient insulin, or when the body cannot produce insulin, or the body cannot use insulin to carry its process. The insulin hormone, it's a hormone, regulates the blood glucose, and as a carrier, it takes the blood glucose from the blood and transport it to the tissues or the organs. So also there is an expression called terminology called hyperglycemia. It's also called raised blood glucose or raised blood sugar, and is a common effect of uncontrolled diabetes, and over time leads to serious damage. The chronic hyperglycemia, not the acute hyperglycemia, but the chronic one makes serious damage to many of the body systems, especially the nerves and the blood vessels. When we see diabetes mellitus around the world, we found that in 2021 there are 537 million approximately from the age from 20 to 79 years are living with diabetes, while this number is projected by 2030 it will reach 643 million, and by 2024 it will reach 783 million by 2045. It is a pandemic. Although it is a non-communicable disease, but it is increasing in number. 3 in 4 diabetic patients live in low and middle income countries. When we see the prevalence of the diabetes prevalence, we found in the worldwide, 1 out of 10 adults in the world has diabetes, 1 of 10. And also, as we have said in the previous slide, it will reach in 2045, 783 million in the world will have diabetes. 195 million of them from age 20 to 44 years, while 588 million from the age 45 to 79 years old. This number is a big number in the future in 2045, according to the International Diabetes Federation. The problem in the undiagnosed person, another alarming point is the undiagnosed diabetic cases, which may lead to many complications and worse prognosis. From global estimates, we can conclude that almost for every diabetic patient, there is another person who is undiagnosed and receives no treatment. When we see this map, we will check here for the percentage increase by 2024. In Europe, the least percentage increase in diabetes number is 13% increase from 67 million to 69 million, while the biggest one in Africa is 134 increase, 100 from 33 million to 55 million. Also, in North America, it is 24% increase from 57 million to 63 million. So we notice that Europe is the least one because they make cycling and lifestyle habits, good and healthy lifestyle habits in Europe than in North America, and the bad habits in Africa. Also in Middle East, our region here in Egypt, it is projected to the number increase to in 2045 to 87% increase from the number reaches from 95 million to 136 million in the Middle East and the North Africa. Why diabetes is a dangerous disease? We notice that 4 million deaths worldwide each year. For every one death, every 6 seconds. Every 6 seconds, there is one death. What are the lifestyle risk factors for diabetes? The WHO, the World Health Organization, said that when your age come 40 years or over, and overweight, when you are overweight or obesity, also the physical inactivity, unhealthy diets, and tobacco use or smoking, family history of diabetes, and history of abnormal glucose during pregnancy are the risk factors for diabetes. Factors that worsen diabetes. Many of the risk factors for diabetes are also complications of the condition. Someone who has diabetes and high blood pressure are at a higher risk for eye and kidney disease. Type 2 diabetes can also lower good cholesterol. So the good cholesterol, the high density lipoprotein cholesterol, will be lower in type 2 diabetes and raise the bad cholesterol, which is the LDL or low density lipoprotein cholesterol. This puts a person at a risk for heart disease and stroke. And why diabetes is so dangerous? It has many related complications. One may have death from complications and not from diabetes. If we see the diabetes-related complications, we see that, number one, everyone has a diabetes. Diabetic adults are found to be 1.5 times, 1.5, at a higher risk of getting a stroke compared with non-diabetics. Also, the diabetic patients are projected to hypertension by 71%. 71% will have hypertension. Also, a kidney disease. Kidney disease, diabetes was listed as the primary cause of kidney failure in 44 of all newly diagnosed cases. Diabetic retinopathy, 28.5%, according to the recent study carried out in Alexandria. 34.6% of the patients were found to have diabetic retinopathy. Also, the cardiovascular disease, the diabetes-related complications. Once you have a diabetes, you are projected to cardiovascular disease by 47%. 1.7 more times more susceptible to die from cardiovascular disease and 1.5 times higher risk of getting a heart attack. Also, the elevated cholesterol levels, according to the ADA, American Diabetes Association, the elevated cholesterol level, when you are diabetic, it will raise the cholesterol level by 65%. Also, not all the diabetic patients are projected to lower limb amputation. These are the diabetes-related complications. When we said that someone has diabetes, diagnosis of diabetes, when the hemoglobin less than or equal 5.6, it is normal person. While the hemoglobin A1C, when reaches 5.7 to 6.4, it is high risk or pre-diabetic persons. When the hemoglobin A1C is more than or equal 6.5, confirmed by repeating the test, it is called diabetes or diabetic patient when it reaches 6.5 or more. While the fasting plasma glucose per milligram per deciliter, when it reaches less than 99 or equal, it is normal person. When it reaches from 100 to 125, impaired fasting glucose. When it reaches the fasting plasma glucose equal to 126 or more, confirmed by repeating the test according to the ADA or American Diabetes Association, it is confirmed diabetic person. When the fasting plasma glucose reached 126 or more, while the postprandial glucose after 2 hours of eating, it reaches 140 to 199, it is called impaired glucose tolerance. When the postprandial glucose reach 200 or more milligram per deciliter, it is diabetic patient. Also, random blood glucose at any time when reaches 200 or more or equal, it is called diabetic patient. We have to know some notifications that A1C should be considered an additional optional diagnostic criterion, not the primary criterion for the diagnosis of diabetes. When feasible, the American Association of Clinical Endocrinology and the American of Clinical Endocrine suggest traditional glucose criteria for the diagnosis of diabetes. A1C is not recommended for diagnosing type 1 diabetes. It is not recommending for diagnosis of type 1 diabetes, while A1C is not recommended for diagnosing gestational diabetes. Here the prognosis and life expectancy. Type 2 diabetes is a chronic condition, as we have said, and that can shorten life. It can shorten life. Many health complications can stem from diabetes. These include heart disease, kidney disease, and nerve damage. And the life expectancy of someone diagnosed with type 2 diabetes at age 50 is 6 years less than someone without diabetes. Here is the dangers, the complications. The life expectancy of someone diagnosed with type 2 diabetes at age 50 is 6 years less than someone without diabetes. There are research study published in 2022 found that the outcomes that controlling weight and the blood pressure, blood sugar, and cholesterol levels can increase the life expectancy of someone with type 2 diabetes by reducing their risk of complications and death. So when control your diabetes, control your weight, control your blood pressure, control and blood sugar and cholesterol level can increase the life expectancy of someone with type 2 diabetes. Here is the outcomes of Lou et al. 2022. The outcome said when you're lowering the A1C, hemoglobin A1C, when you're lowering it from 9.9% to 7.7, you will improve the life expectancy with the following, with 3.4 years. When you lower the body mass index from 41.4 to 24.3, improve the life expectancy by around figure 4 years. When you lowering the systolic blood pressure from 160 to 114, it will improve the life expectancy by 1.9 years. When you're lowering the low density lipoprotein cholesterol from 146 to 59, it will improve the life expectancy by 0.9 years. Here is the Lou J et al. Outcomes. Let us go to the lifestyle medicine. The lifestyle medicine in diabetes mellitus management. There are 6 compartments in the lifestyle medicine to manage diabetes mellitus: stress management, social support, sleep well, avoid risky behaviors, and the nutrition and exercise. Where's the diet? The diet, eating a healthy diet with minimal sugar, carbohydrates, and alcohol can help keep blood sugar under control. Research shows that at risk for diabetes can reduce that risk by 58% if you lose 7% of their body weight and exercise 150 minutes weekly. This means 30 minutes every 5 days in a week. 5 days in a week in 30 minutes exercise will reduce the risk of diabetes by 58%. Eating a wide variety of healthy foods can help manage blood sugars and reduce the likelihood of type 2 diabetes complications. This food includes full fiber grains like oats, brown rice, and whole wheat, الحبوب الكاملة, non-fat and low-fat dairy products, and lean meat. Let us go inside the American Journal of Clinical Nutrition. There is published research in March this year, 2024, about sugar sweetened or artificially sweetened beverage consumption, physical activity, and the risk of cardiovascular disease in adults. It's a prospective cohort study. What about the sugar sweetened or artificially sweetened beverage consumption and its correlation to physical activity and the risk of cardiovascular disease in adults? So this published paper outcomes are the sugary drinks. Sugary drinks increase the risk of cardiovascular disease regardless of how much you exercise. This means 1 glass of cola every day will increase the risk of cardiovascular disease. 1 glass of cola every day will increase the risk of cardiovascular disease regardless of how much you exercise. In February 2024, daily consumption of sugar-sweetened beverages may heighten the risk of developing cardiovascular disease, even among those with above average physical activity levels. According to a new study led by Harvard, the School of Public Health, the study published in January in the American Journal of Clinical Nutrition. Here is to sum up of my slides in the diet slides. The Daily Meal Journal said sugar is the new tobacco. Sugar is the new tobacco. The Daily Meal announced that the sugar is the new tobacco. Sugar is the new cigarettes. Sugar increases insulin. Insulin increases fat storage, and it's addictive. They found that 93% of lab rats choose sugar water over cocaine, over cocaine. So sugar is the new cigarettes. This is proved experimentally by the lab rats. How sugar affects the body? 120-ounce bottle of soda contains 65 grams of sugar, or the equivalent of 16 sugar packets. Here, what happens when excessive sugar enters the body? Let us go in this journey. The brain, you can thank your brain for that 3 p.m. chocolate craving. That's because sugar stimulates dopamine, a feel-good chemical that triggers sugar cravings and can affect your mood. The heart, when you take 120-ounce bottle of soda, it will turn out a diet that's high in sugar. Like a diet high in sugar can be bad for the heart. Too much sugar in the bloodstream and high insulin levels increase the risk of heart disease over time. Also the liver, excess sugar or 120-ounce bottle of soda will make excess sugar in the liver, takes a toll on the liver too, and the quick sugar load cause a fast rise in blood sugar level that can overwhelm the liver and lead to fatty liver and cirrhosis over time. The joints also eating too much sugar or is the new to the IDF International Diabetes Federation recommendations for healthier diet. Choose water. Choose water, coffee, tea instead of fruit juice, soda, or other sugar sweetened beverages. Eat at least 3 servings of vegetables every day, including green leafy vegetables. Eat up to 3 servings of fresh fruit every day. Fresh fruit, not juice, because the maximum milliliter of juice, of natural fresh juice every day is 150 milliliter. You can take fresh juice as a maximum of 150 milliliter per day, not more than that, because if more than that, it will go to sugar bad effects. Choose nuts or a piece of fresh food, unsweetened yogurt. Limit alcohol intake to a maximum of 2 standard drinks per day. Choose lean cuts of white meat, poultry, or seafood instead of red or processed meats. Choose peanut butter instead of chocolate spread or jam. Choose whole grain bread. It's very important because the flour or rice or pasta instead of white bread or rice or pasta. Choose unsaturated fats like olive oil instead of saturated fats, butter. The exercise. Let us go to the exercise. Moderate intensity exercise of 150 minutes per week, as we have said, has been shown to improve blood sugar control and to lower the blood pressure. It may also reduce the likelihood of developing heart disease. To get the most benefit for blood sugar control, the muscles need to be in consistent state of increased glucose uptake. This means that there should not be more than 48 hours between exercise sessions. So not more than 2 days between exercise sessions. The exercise does not need to overly intense. It should be hard to sing, but still be able to hold the conversation. While exercising, try changing your routine to keep it interesting, or joining an exercise or listening to music. What is the benefit of exercise? Reduce the risk of diabetes. Swimming, dancing, cycling, like in Europe. So the percentage in Europe is less, the less one, 13% increase is projected in 2045 because they make cycling. While in America, 24% increase. While in Africa, 137% 7% increase, while in the Middle East region, 87% increase from now to 2045. 30 minutes of exercise can reduce the risk of diabetes by 40%. Quitting smoking. Smoking is one of the causes of type 2 diabetes. Those who smoke cigarettes are 30 to 40% more likely to have type 2 diabetes than those who don't smoke. For those who already have type 2 diabetes, smoking makes it harder to manage the condition. Those who do stop find it easier to control their blood sugar. CDC, or Centers for Disease Control and Prevention, a study found that a woman from 50 years to 60 years of age who quit smoking lived about 1 year longer than those who didn't. Sleep. Not getting enough sleep is associated with pre-diabetes, insulin resistance, and type 2 diabetes. There is also a connection between type 2 diabetes and obstructive sleep apnea. Approximately 2/3 of people with type 2 diabetes also have obstructive sleep apnea. Regular uninterrupted sleep should be a priority as it can help improve insulin sensitivity. Medications to manage diabetes. The lifestyle changes are a large part of improving the prognosis of diabetes. But along with the lifestyle changes, people with type 2 will also likely need medications to manage their conditions. Someone with type 2 may take several types of medications, include insulin, metformin, glipizide, and glimepiride, and GLP-1, and sodium glucose transporters inhibitors. Monitoring blood sugar. Someone with type 2 diabetes should closely monitor their blood sugar as prescribed by the healthcare provider. There is a continuous glucose monitor. CGM is another option, but is typically used in people with type 1 diabetes. And the CGM uses a smaller sensor that tracks blood sugar all the day and night. Taking care of your heart. Taking care of your heart. Diabetes and heart disease are often seen in the same people. By making lifestyle changes like exercise and dietary changes, smoking cessation, and glucose monitoring, people with diabetes can also help with their heart health. High blood sugar can damage blood and nerves that control the heart because hyperglycemia change the sodium-potassium channels along the arteries also. Lasting lifestyle changes can lower the risk of heart disease and improve life expectancy for the patients. Diabetes methods. 6 diabetes methods. Myth number 1, you need a special food if you have diabetes. No, foods like chocolate, cakes, and biscuits marketed towards people with diabetes may be sugar-free, but this does not make them a good choice. They are often still high in saturated fat and calories. And the sweetener can have a laxative effect if too much is eaten. These products often also come at a price premium. So what is the solution? Better to save your money and have a small amounts of the standard products occasionally instead. Myth number 2, people with diabetes shouldn't eat. Fruit is a healthy choice, and along with vegetables, should form a large part of healthy, balanced diet for diabetes. Fruit is higher in natural sugar than vegetables, but still lower in sugar than cakes or biscuits or sweets. And it contains other nutrients and fiber. If blood glucose levels are high, it's unlikely that it's the fruit in your diet. Take care. That is the problem. The fruit in your diet, that is the problem. Look at other sources of sugar in your diet. Myth number 3, diabetes is caused by eating too much. Type 1 diabetes is not caused by diet or lifestyle choices, as all of us know this. Happens when the cells that produce insulin in the pancreas are destroyed by the immune system. Where type 1 diabetes is not caused by diet or lifestyle choices. It's also not true to say that type 2 diabetes is caused by sugar. However, the chances of developing this type of diabetes is greater if you are overweight or obese. A high sugar diet is often a high calorie diet, and too more calorie can lead to weight gain. On average, what is the solution? We are eating more sugar than recommended. So most of us could benefit from cutting down or on sweet treats and choosing sugar-free drinks and checking ingredients list for added sugar. Type 2 diabetes is a mild diabetes. Myth number 4. No, it's important to control your condition well to avoid developing complications which can include sight loss and even amputation as an increased risk of heart attack. People with diabetes have to follow a special diet. The diet for people with diabetes is the same as it is for everyone, a healthy, balanced diet. This includes a plenty of fruit and vegetables, as well as pulses, fish, eggs, and lean meat and low-fat diet. What is the solution? Keep food like cakes, biscuits, and sweetened as just small amounts and aim to stick to sugar drinks like water and unsweetened tea or coffee. Myth number 6 is the last one. No one in my family has diabetes, so I will not get the disease. Fact. The fact said it's true that having a parent or sibling with diabetes increases your risk for getting the disease. In fact, family history is a risk factor for both type 1 and type 2. However, many people with diabetes have no close family members with diabetes. Lifestyle choices and certain conditions can increase your risk for type 2 diabetes. This include being overweight or obese, having pre-diabetes, polycystic ovary disease, and gestational diabetes. Being Hispanic, like Hispanic man, Hispanic American, African American, or Indian, Alaska, being age 45 or older, you can help reduce your risk by staying at a healthy weight and exercising most days of the week and eating a healthy diet. These my references, the Standards Care in Diabetes 2024. Any questions? Thank you.
Thank you so much, Dr. Musaad, for your insightful presentation on the critical role of lifestyle in managing type 2 diabetes and obesity. Your expertise and valuable information have certainly provided us with a deeper understanding of this important topic. I'm sure that our participants have gained valuable knowledge on lifestyle choices can significantly impact disease prevention and management. We have a question from someone. They're asking if type 2 diabetes is more common in people who eat meat and fatty products.
Type 2 diabetes not more common in people who eat meat and fatty products, but the fatty products is risky. The fatty products is risky for that. Also, a high percentage of protein is more likely to cause low density lipoprotein cholesterol raise. So you have to take your healthy, balanced diet. Healthy, balanced diet. And I said in the diet, get away from sugar, because sugar is the new cigarette smoking tobacco. Sugar. All of us go to many sugary products in the market, like caffeine in the morning, caffeine with sugar in the morning, iced mocha, iced latte, and these products contain sugar. So I have to go to the most balanced protein and unsaturated fatty products. Using olive oil, using fish products, using vegetables, less of fruit juice, less than 150 milliliters. Any another question?
Well, I think our moderator lost connection. Yes, there is another question. It says that is it also forbidden to eat 3 to 4 fruits at the same time in diabetes?
Yes, since we have, I said before, the sugar, the 3 to 4 is, it depends when you monitor your blood glucose. If the 3 or 4 fruits, what are their types? You have to take one big banana, or one big orange fruit, it will be fine. But if you take more, this increases the percentage of sugar to your blood body. So you have to take one only, 3 or 4. It depends what are the types of fruit. What are the types? Any type contains more sugar, it will lead to increase your blood glucose level. So I have to choose what are the fruits. So one apple only or one banana is more likely to be safe in diabetic patients.
All right, thank you so much. We also have another question from Riham. They're asking why A1C is not recommended in gestational diabetes.
Sorry, repeat the question again.
Right. Riham is asking why A1C is not recommended in gestational diabetes.
The A1C is not a confirmatory test. It's not a confirmatory test for the to say that it is diabetic or not. The fasting plasma glucose and the postprandial glucose is the recommended way, primary way to confirm diabetes. While the A1C, the recommendations of the A1C is not recommended in type 1. In type 1, it is recommended for monitoring every 3 months to get how the blood glucose level, how the patient compliance on the medications.
Okay, thank you so much for responding to our questions, Doctor. We just want to give tell our participants that if you still have questions for Dr. Yassir, you can keep on putting them in the chat box. And yeah, we're gonna give it back to our second speaker for today. Unfortunately, our moderator lost the internet connection, so I'm not really sure who's going to be coming up next. So our next doctor, apologies for this mishap. You can take over. Thank you.
Okay. Sorry for interruption, Michelle. I can take the lead. So our next lecture or session will be given by Dr. Hagar Awad. She's a clinical lecturer at College of Pharmacy at Qatar University. She will give us a brief about understanding the impact of lifestyle in the treatment and prevention of chronic obstructive pulmonary disease. So the floor is yours, Dr. Hagar. So and happy to listen to you.
Assalamu alaikum. Good evening, everyone. Thank you very much for the invite. Thanks for the IVPN student, for the International Pharmacy, the EMRO or the Eastern Mediterranean regional office of the IPSF. Thanks also for the Lebanese Pharmacy Students Association. Thanks also for Dr. Yasser for this informative presentation about diabetes. And we will continue maybe in the same theme of empowering lifestyle for better management and prevention of diseases. And the topic that I'm covering in particular is COPD, chronic obstructive pulmonary disease. Just before I start, I would like to share with you that I don't have any relevant conflict of interest to disclose. So I'm purely presenting maybe science and some health promotional activities. My objectives for this portion of the presentation is that I want to give you some information about how COPD is common and how worldwide and also in our region, and identify the common risk factors. By identifying the common risk factors, this will help you understand later on why we have lots reliance on like lifestyle changes and how lifestyle can really affect the prognosis of COPD and how to manage it. We cannot rely mainly on medications because these are not going to be effective without some like really active non-pharmacologic interventions and lifestyle modifications. Also part of our understanding, we want to briefly understand the pathogenesis and the prognosis of COPD, how it happens and what are the damages that happen to the lung and pulmonary system with the COPD. Then we want to discuss how this can impact the life and quality of life of patients who are diagnosed with COPD. And then we will go over some non-pharmacologic and lifestyle management for COPD, along with recommendations based on evidence. So before I go into in-depth information about COPD, it's really important to define what is COPD. And you can see that this word preventable is bolded and it is red because it is the key word here that I want to stress on. It is a preventable disease, but unfortunately, once it develops, it can be difficult to revert everything back because usually the COPD does not occur in 1 year or 2 years. Usually it happens after prolonged exposure to some insults and toxins that are affecting the pulmonary system. So the definition of it is a preventable chronic disease of the airways, and it is characterized by gradual and progressive lung function of the lung. This can be manifested as airflow limitation, and unfortunately, it is not fully reversible. So, for example, if we compare it to asthma, when the patient is diagnosed with asthma, once they use the inhaled steroids, the lung function can improve. But with the COPD, once it is diagnosed, usually patients can have some prognosis, especially if it is not accompanied by good and serious actions toward their lifestyle, toward healthy lifestyle. So here, going to the risk factors of COPD, as you can see here that smoking is the major one. And a lot of patients might say that, well, I have people around me who are smoking and they never have COPD. Okay, but in the same time, smoking and continuing to smoke is putting your lung at risk of developing COPD at any point. Yes, maybe patients might live without COPD, but it might be undiagnosed, and patients can catch some other conditions, such as, for example, lung cancer and maybe some emphysema or some source or manifestations of COPD that are not as severe to the degree that it is diagnosed with COPD. In addition to that, there is also a very important factor here that might lead to COPD is exposure to some toxins. These toxins, for example, in relation to our culture, maybe bukhur is one of the things that we here, for example, in the state of Qatar, we have, and I think this is also applicable to many of the Gulf region, they consume bukhur a lot. And we've seen that, for example, some elderly, they never smoked, and yet they developed COPD because of the exposure, or, for example, because of the exposure to passive smoking. So all of these, any exposure to toxins, especially if it is prolonged, it might incur some risk factor for development of COPD. Alpha-1 antitrypsin deficiency is one of the rare maybe congenital genetic disorders that is associated with deficiency in this important protein that is produced by the liver, but its role is mainly to protect the lungs. So this is something rare. And unfortunately, when COPD is developed due to this condition, we don't have lots of interventions here to do, but there are some medications that are undergoing phase 2 or phase 3 trials, and maybe they will be available in the market. But until this moment, we don't have any medication that is approved for this, but we need to treat the condition as COPD. Also, some risk factors, but all these risk factors are very rare in comparison to smoking. So impaired lung function or lung growth during gestation, birth, and childhood, in addition to exposure to oxidative stress, like, for example, in the, industry, depletion of antioxidants in the lung, because antioxidants are protective for our lungs. Respiratory infection, but this is to a very lesser extent than smoking. So smoking is the major one that we are tackling today, and it is proven later on that once you quit smoking, the lung function will start to regain some of its ability. Do you think that COPD is not common in our country? Unfortunately, we don't have the diagnosis. We don't have the awareness toward appropriate diagnosis of COPD. Thus, you can see that in our countries, these studies are not very commonly. These studies are not commonly published. This study was published in 2012. And it covered some of our countries in the region. And the numbers here, as they said, that the numbers are not very representative of the actual number of COPD patients. So reporting is not as effective. And we want more awareness among the public that COPD is something that you need to report, and you need to seek medical help once you start to have, for example, dry cough that is not going away, symptoms of shortness of breath, or any symptoms from the symptoms that we will be discussing shortly. So worldwide, in the Western countries, in the industrialized countries, it is more reported, there is more awareness about COPD, and it accounts for about 10% of the population. Individuals, especially for those who are above age of 40, and it affects equally males and females without any gender effect. So just going very briefly over the pathophysiology of COPD, because I'll not overwhelm you with lots of information here, but just we want to know how smoking can impact our lung and how it can affect our lung function over the time, and it can lead to COPD. In general, we said that oxidative stress, smoking, exposure to some toxins, over some time, it can damage some of the delicate tissues that are found in our lungs, and their function is mainly to exchange gases and to help us utilize the oxygen from the environment. So cigarette smokes and environmental particles, in addition to some host factors, as we said, for example, some people are more susceptible than others to develop COPD. This will trigger some inflammatory reactions locally in the lungs. In general, in our pulmonary system, we have we have antioxidants, and we have also antiproteases. Those are protective factors that are normally found in our lungs. They found that sometimes under the effect of toxins, sometimes some host factors, those antiproteases and antioxidants might be a little bit not that much active. So this will give, and also under the effect of inflammation, those will be a little bit suppressed. So this will lead to oxidative stress, and this oxidative stress over time, over years, will lead to some pathological changes that will be manifested as COPD. What are these pathologic changes? Mainly, we have two things that we need to consider when we speak about COPD. We have two terms that are really important to understand while we are talking about COPD. Mainly, we have chronic bronchitis and emphysema. The chronic bronchitis is defined as presence of chronic productive cough for 3 months during 2 consecutive years. So we need here to be very cautious about the history taking and also in the differential diagnosis of COPD, because we don't want to diagnose a patient with COPD while the patient might have TB, or the patient might have lung cancer, or the patient might have, like, for example, drug-induced dry cough, like, for example, with ACE inhibitors. So we want to be very thorough with regards to the clinical presentation, history taking, and also diagnostic tests, and radiology, for example, labs, all this. In addition to that, we have another factor that plays an important role in the development of COPD, which is emphysema. Emphysema is mainly something that is a permanent damage. It is abnormal enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls without obvious fibrosis. So what does this mean? We have in the alveoli, we have those small air sacs that look like a grape. Those are grape shaped. So those allow more distance, more surface for the gas exchanges. In addition to that, those are very tiny molecules, or having very tiny walls that allows sufficient exchange that happens within 1 second, exchanges of gases. And those are fully nourished with blood. But in the same time, those, as I said, those are delicate molecules or tissues that they will not stand the overproduction or over stress that is happening because of exposure to toxins. So what happens is that over time, the body will say, okay, alveoli will not be effective enough in withstanding all these toxins and oxidative stress. So they will be damaged and they will be enlarged. So instead of having small, tiny tissues that are allowing good like gas exchanges, those will be enlarged and they will be bigger in size. But in the same time, those will not be as effective in gas exchanges as the regular alveoli. And unfortunately, this damage is permanent. That's why the COPD is a permanent disease, but it is preventable. And we can control some of its symptoms. We can slow its progression, definitely. So this damage might happen to some loops of the lung. But if we continue to get the exposure to the toxins, more and more damage will happen. And the more damage to the alveoli, the more emphysema, the less ability for the lungs to function. So here, knowing all of these, we can see some features between COPD and asthma. We have chronic bronchitis, we have emphysema, and we have the shortness of breath and hyperresponsiveness that is happening in asthma. So overall, this can lead to something called airflow obstruction. So the clinical presentation, as I said, usually the patients might have regular cough that is not going away. And the patient might tell you that this is especially worsening in the morning, or for example, at night, I cannot sleep well. And there is some products of productive cough, but this cough is not like purulent. Usually it is like transparent. It is not green, it is not yellow, because if it is green and yellow, that means there is bacterial infection, and usually those patients might need some antibiotics. But in general, this regular cough that is happening is accompanied by production of little phlegm, and this phlegm is usually transparent. The patient might be breathless if they have any activities, if they do any activities, and usually this happens later on. So until like massive damage happen, patient might not have breathlessness. Also, the patient might have elevated jugular venous pulse, and this can be mixed with heart failure, and we need to be careful in the diagnosis as well. Peripheral edema, which also can be seen in cardiovascular diseases as well, or renal. Thoracic examination patient might be seen as hyperinflated chest with hyperinflated chest. And this why? Because of the emphysema, the size of the lung is bigger, and also because the patient is using extra muscles to breathe. The patient is pushing hard on the lungs to breathe, and the patient might have also wheezing. In addition to that, there are some other characteristics, like, for example, diffusely decreased breath sound, prolonged expiration. Patients might be obese. This might not be obesity. It might be due to water retention. Patient might have symptoms similar to right-sided heart failure. The patient might be also using accessory muscles for the respiration. We are blessed that we are not having any efforts, we are not paying any efforts to breathe. But unfortunately, those patients might be paying lots and lots of efforts to push their lungs hard in order to breathe. So you can see that the chest might be enlarged, and the patients might be big in the chest size, and this is called parallel chest. So the diagnosis of COPD, I will not go over it into with details, but in general, we do lung function test, and we care mainly about the first thing that we care about is the forced expiratory volume. Usually, it will be the FEV1 over the forced vital capacity. Usually, for those patients, it will be less than maybe 70%. That means in that case, there is some impairment, and we usually label the patient along with the history and other symptoms as COPD patients. Then we subdivide the patients, or we stratify patients based on their lung function test into groups. For example, the GOLD is the Global Initiative for Management, or this is the guideline, the worldwide accepted guideline for COPD, the GOLD guidelines. So they stratify the patients based on their severity of the impairment of the FEV1 after the establishment of the diagnosis. So mild, the lower the lung function test, the severe the symptoms. So between mild to very severe. So the lower the number, that means the severer the condition. So here, I know that I'm not supposed to cover the pharmacologic management because it will be a longer one, but just to keep you posted about, for example, after we establish the diagnosis of COPD, we need to do assessment of the airflow obstruction and stratify the patients based on that. We need after that also to do the assessment for symptoms and risk for exacerbation. And then after that, we need to do the spirometry. Based on it, as I said, we stratify the patients based on the grade from GOLD 1 to GOLD 4. And then the guideline actually stepped further, and they do some other assessments because as I said, this will affect the lung function. This will affect the quality of life of the patients. This will affect also the patient's ability to perform even daily activities, like, for example, combing the hair, dressing, undressing, walking. All of this might be impaired. That's why we need to consider other factors rather than the lung function test, the objective one. We need to look at some subjective data. We need to ask the patients, for example, how many meters they can walk without breathlessness. For example, if they are able to do their activities. And they have multiple assessment tools. We have the MMRC and the CAT score. The CAT score, the higher the number, the higher risk of or the higher impact on the lifestyle of the patient. And also they need to consider the exacerbation, because any exacerbation that leads to hospitalization will increase the risk of death by 50% in the coming year. That's why it is very important to consider all of these when we deal with those patients. This staging system has been developed over years and years, because they started with just COPD treatment ladder. Then they moved to ABCD. Then they moved to APE, considering the exacerbation risk, the risk for hospitalization due to exacerbation, the performance of the patient, and also the degree of impairment. So based on this, after we do that, we need to set some goals of therapy. What are the goals that we want to achieve? We want, of course, to relieve the symptoms, want to improve exercise tolerance and ability of the patient to perform their lifestyle or their life. Prevent disease progression, of course. We want to prevent and treat any exacerbation and reduce mortality. How we can achieve this? We have multiple options, and you can tell without even going over this. Smoking cessation. Smoking cessation, even for all patients, even before the diagnosis of COPD, it should be encouraged. And it should be, for example, awareness should be raised. Okay, you are putting yourself at risk of lung cancer, but also there are some other things. COPD is a progressive disease. And as the disease progresses, the patient might lose lots of ability to do even some normal tasks, like, for example, as I said, cooking, eating, sleeping, because they need to sleep while sitting in the sitting position. So all of this lifestyle or quality of life will be impaired, and many of those patients might need even psychological support at the end. So we don't want to reach that. One of the steps that we should be encouraging our patients is a smoking cessation. Smoking cessation has been studied in multiple studies, and all of them, they are confirming that even after the establishment of the diagnosis of COPD, it is really important that we quit smoking and we encourage the smoking cessation. And we can aid the patients with medications, we can refer patients to clinic, but the most important thing is to help the patient quit smoking. One of the studies here that was published in 2004 in the American Thoracic Society and European Respiratory Society, they found that patients who quit smoking and they were able to sustain their quitting, they were having better preserved FEV1. So instead of declining and progressing of the disease, still they were preserved. The lung function was preserved. And when we compare this to intermittent to the quitters and continuous smokers, the results were way above this. So preserving the lung function can be achieved by smoking, along, of course, with the medications. But with medications and smoking, the lung function will continue to deteriorate. Another study that was published actually in 2023, they found that after 1 month only of quitting smoking, the patients were performing very well above the normal level or their baseline. So FEV1, for example, increased. FEV1 increased, and the p-value here, you can see it is significant. FVC percent of predicted was also improved. It is not significantly it is not statistically significant, however, it is clinically significant as they reported. You can see that even other things, like, for example, the MMRC, which is performance activity, patient average was scoring 1.5, the higher the worse. And you can see here this grade decreased, which means the patient is doing better, even after 1 month only of smoking cessation. In addition to that, you can see that even total cholesterol and HDL improved. So smoking cessation was really beneficial by all means. So here from the GOLD guideline, these are some pharmacologic and non-pharmacologic interventions, knowing that we are not covering here the pharmacologic, so I'll just skip this part, but those are, here the summary of this table is that what are the interventions that are supported by evidence, mainly randomized controlled trials, well-designed randomized controlled trials, or, for example, strong evidence. So non-pharmacologic, mainly smoking cessation was the major one, and they found that it can be even for patients who are asymptomatic or mildly symptomatic. It can be beneficial for them as well. Pulmonary rehab, and pulmonary rehab falls under the physiotherapy, respiratory therapy, where they educate patients in particular to use less effort to breathe, because we don't want the patients to force the lungs too much, and this will consume their energy. Long-term oxygen use was also given, and especially if the patient is deteriorating and they are not able to maintain the normal level of oxygen in their plasma. A non-invasive positive pressure ventilation, or, for example, lung volume reduction therapy, surgery, which is surgical removal of some of the loops of the lungs that are affected by emphysema, because we don't want them to have, like, at the end, abscess, maybe infection, and this can kill them. So maybe sometimes, especially if it is massive, we can remove that part of the lung. And this was shown to be effective in some patients, but at least for us as pharmacists, we can go with smoking cessation. And we have also some other things, like, for example, education. Because sometimes some patients might not correlate smoking to COPD or deterioration of COPD, or they might say that, well, I have already the disease, so what will benefit me to stop smoking? So it's really important that you should educate the patient, and you should be involved in education for patients to stop smoking, because this is the major intervention that we need to do. If we are intervening pharmacologically, without smoking cessation, the lung function will continue to deteriorate. Appropriate administration on use of medication is really important, and those are proven by studies that they were really of benefit for patients, and this was clinically and statistically significant. You need also to recognize and treat any exacerbation. This is really important. One of the lifestyle changes or lifestyle interventions that we should encourage our patients to is to early detect the exacerbation, because you want to intervene early with the supportive medications and the, for example, the systemic steroids before the exacerbation can lead to hospitalization. Because, as I said, exacerbation that leads to hospitalization might increase the risk of death even after the 1 year after the exacerbation. In addition to that, we have also the vaccination. Vaccination is also considered part of the non-pharm. So yearly flu vaccination, so education here is really important, pneumococcal vaccine, and many others. And the guidelines suggest here, I think in the summary here, that influenza vaccine, COVID-19, of course, pertussis, shingles, and pneumococcal vaccination, influenza, RSV, all of these are recommended to be given, and the CDC, along with the GOLD guidelines, they jointly publish this and they recommend that. So in the patient who have stage A, which means the patient has less symptoms and less risk of hospitalization, smoking cessation is the one recommended by all guidelines. In addition to that, also physical activity, because we want to strengthen our body in general and maintain some physical activity beside the vaccination. As the disease progresses, also smoking cessation is recommended, and usually we refer the patient to pulmonary rehab, where they can do some exercises to reduce the consumption of energy and muscle use in forcing the lung to function. And in addition to that, we also encourage physical activity, and we ask patients, for example, to sit for some time to catch breath and then start again. So the patient can walk for maybe, sometimes some of these patients cannot walk for more than 10 meters. So they need to walk and then stop for breathing and then continue again. So after some time, they found that the distance the patient is able to walk without feeling breathless is increasing over time. But this also needs patience and education. Just to summarize everything, the risk factors, as I said, smoking and other air toxins, alpha-1 antitrypsin deficiency, and the pathophysiology of COPD is mainly due to multiple risk factors. But once we start to develop emphysema or chronic bronchitis, along with shortness of breath, this is where we really call this as COPD. The non-RX or the non-pharmacologic interventions, lifestyle interventions, is smoking cessation, vaccination, and education on everything. We need to educate patients and provide them with full education. And this is the end of my presentation. It will be my pleasure to answer any questions you might have. Thank you.
Thank you so much, Dr. Hager, for the insightful presentation on the impact of lifestyle on chronic obstructive pulmonary disease. Your expertise and insights are greatly appreciated. Dr. Hager, how can we differentiate between asthma and chronic obstructive pulmonary disease clinically?
Okay, this is an excellent question, actually. Those, as I said, they have lots of common features, but in general, we have some factors that we need to consider in the patient characteristic. Usually, asthma occurs in early age of life. For example, usually asthma, the first maybe attack might happen in childhood, while usually the COPD happen in advanced age. This is first. The second thing is that asthma usually happens in people who are not having any risk factor. Like, for example, they are not having any lifestyle exposure to toxins, such as smoking, for example, while COPD is mainly caused because of prolonged exposure to the toxin. And another thing is that this can be done by some objective measures, like, for example, the testing of the sputum sample, and they see the presence of the eosinophils. Usually in asthma, we have massive immune involvement, because it is an autoimmune disorder that is localized to the lung. And usually the patients might have lots of other allergic reactions, like, for example, hay fever. The patient might have also eczema in the childhood. So there are some links to the immunity. But here we don't have that. So this are some features or some tips to differentiate between asthma and COPD.
Okay, we have another question here. Someone is asking if can COPD symptoms be mistaken as a symptom leading to angina?
Actually, there are some complications of COPD that can be manifested as left-sided heart failure. And overall, I think because of the hypoxemia, this might lead to deprivation of many parts of the body from oxygen, including the heart. So definitely it is a risk factor for multiple cardiovascular diseases, but the link is well established with heart failure, and especially left-sided heart failure.
Okay, thank you so much for your insights, Dr. Hager. It was very informative presentation. Thank you.
Thank you. Thank you.
Last but not least, let me introduce you to our final speaker, Dr. Noura Mersaid. Dr. Noura Mersaid holds a Bachelor of Pharmacy, a Master of Science, and a PhD in Clinical Pharmacy from Ain Shams University in Egypt. With 18 years of academic experience, she is currently a lecturer, assistant professor in pharmacy practice and clinical pharmacy at Future University in Egypt. Her research includes cardiovascular medicine, critical care, oncology, and pain management. Today, she will be discussing healthy choices, healthy heart, understanding lifestyle influence on hypertension, dyslipidemia, and their consequences. Please welcome Dr. Noura Mersaid. The floor is yours.
Thank you. Thank you, doctors. Thank you for the sweet introduction. And thank you for the IVPN Student Network, as well as the International Pharmaceutical Students Federation and the Lebanese Student Association for this collaboration and for allowing me to contribute to this webinar. Thank you, of course, to all the participants, as well as the previous speakers, Dr. Yasser Omar, as well as Dr. Hagar, for their insightful discussion. And we're continuing here with the same theme regarding empowering lifestyle for better disease. And this session is a conclusion to this webinar where we'll be discussing healthy choices and understanding lifestyle modifications and how they influence diseases such as hypertension, dyslipidemia. And as the title suggests, we will be focusing on those two diseases, basically hypertension and dyslipidemia. And without going through lots of details regarding the disease, hypertension is basically elevated blood pressure, which is systolic and diastolic blood pressure, and dyslipidemia usually means elevated LDL cholesterol, which is known as the bad cholesterol, and reduced HDL cholesterol, which is known as the good cholesterol. So why are we focusing on those two specific diseases? First of all, cardiovascular disease is the #1 cause of death in the world, usually because of coronary artery disease and myocardial infarction. And two of the major risk factors for coronary heart disease are hypertension and dyslipidemia, along, of course, with diabetes mellitus, smoking, and obesity. So we need to focus on those two important diseases because they're major risk factors. And the problem with hypertension and diabetes is not the elevated blood pressure. It's not the elevated readings of blood cholesterol levels. It's in fact that when these diseases or these conditions are left untreated, they end up with complications. So they might end up with end-stage organ disease, such as renal failure. They might result in heart diseases, heart failure, and stroke. We'll start with the epidemiology. Hypertension has a high global burden. It affects almost 1.5 billion people in the world. And we're almost approaching 30% of the global population are actually suffering from hypertension. And as you can see in this map, the world map, where the dark shades indicate the higher prevalence, we can clearly see that countries in the Middle East and, for example, countries like Egypt, they actually have high prevalence of hypertension. Moreover, in terms of dyslipidemia, in the past 30 years, it has become a more burden globally. Dyslipidemia, the most common form is hypercholesteremia. Hypercholesteremia, especially that involves the elevation level of LDL cholesterol. This is the most prevalent form of dyslipidemia. And obviously, it's a risk factor of coronary vascular disease and can be an 8th cause of death in the world in 2019. It's also responsible for atherosclerosis and can result in poor cardiovascular outcomes. So basically, those two diseases, they are highly prevalent, and they are obviously, if left untreated and left unmanaged, they might end up with poor cardiovascular outcomes and death and mortality. So we will be discussing in this session, mainly we'll be focusing on non-pharmacological and lifestyle changes. And the reason for this is because the two most important panels that I will be discussing, or the literature evidence, as well as the large studies that have been conducted regarding those two diseases, they have indicated that lifestyle modification is the cornerstone, not just for the primary and secondary prevention, but also in the treatment. So for people that are diagnosed with hypertension, or they are diagnosed with dyslipidemia and are being treated with pharmacological medication, it is unlikely that they will reach their treatment goals unless it is accompanied with non-pharmacological and lifestyle modifications. So this is the key stage in treatment. And regardless of whichever severity stage of hypertension or dyslipidemia, non-pharmacological management and lifestyle modification is the common management strategy in all the stages, whether they're mild or severe. So basically, the findings that we're going to be discussing, or the recommendations we'll be discussing throughout these slides, will be based on evidence, not just random studies, but basically a pooling of the results of all those studies. In addition, we will these literature evidence, they indicate that we have to start those lifestyle medications as early as possible from childhood, and it should be maintained throughout adulthood and throughout life. And that means there's an important role to be played by the family members of the children, also in schools, also the government. They all have to take, particular roles in order to ensure that these life habits are instilled as early as possible. So we will be focusing on recommendations based on two important panels. One of them is the International Society of Hypertension. This will be mainly focusing on the recommendations for hypertension. And this is obviously in accordance with the European Society of Hypertension. For dyslipidemia, we'll be following the recommendations based on the National Cholesterol Education Program. And this is, of course, endorsed by the American Heart Association and as well as the European Society of Cardiology. So lifestyle recommendations, can be subdivided into several key factors or several points. So we will be discussing throughout these slides healthy eating and nutrition. And this is one of the foremost important lifestyle recommendations for those particularly two diseases that we mentioned. Also, we will be discussing the impact of physical activity and exercise, how to reduce your body weight, and how reaching optimum and goal body weight can help in management and prevention of those diseases, as well as the impact of prevention of exposure to smoking, as well as pollution, also reducing stress and encouraging good sleep habits. And as you can see, those points that I mentioned actually overlap with a lot of the recommendations for diabetes that were mentioned by Dr. Yasser Omar, basically because they sort of interline both diseases, since they're all risk factors for cardiovascular outcomes. So we're going to start with the first key lifestyle recommendation, which we're going to focus on, is nutrition. And nutrition, or healthy eating, there are different eating approaches or dieting approaches that can be undertaken. Research indicates that one of the two healthiest dietary recommendations that can be managing whether dyslipidemia or hypertension is the DASH diet. DASH diet is also known as dietary approach to stop hypertension, and the Mediterranean diet. The DASH diet mainly involves increasing the servings on proportions of fruits and vegetables, reducing obviously salts, reducing refined sugars, also carbohydrates in the form of whole wheats, and dairies in the form of low-fat dairies rather than high-fat dairies. Also, the use of nuts and lean proteins are a cornerstone in the DASH diet. It is also important to reduce fats in terms of saturated fats, cholesterol fats, and replace it with monounsaturated and polyunsaturated fats. Obviously, also refined sugars should be avoided in the DASH diet as well as the Mediterranean diet. So this sort of diagram, it kind of summarizes what to avoid and what to encourage in eating. So we basically limit fatty meats, and we basically focus more on lean meats, mainly poultry and fish. Full-fat dairy products such as cheese, they're probably avoidable, and we instead replace with low-fat dairy. Also, we increase the vegetables and fruit portions in our diet, and we also encourage eating nuts and seeds in moderate amounts. And obviously, carbohydrates, we usually recommend using whole grains and whole wheat products rather than sugars and sweetened products. A continuation to healthy eating in terms of saturated fats. For dyslipidemia, it is recommended that we reduce the saturated fats percent from the calorie intake to less than 7%. We also replace it with monounsaturated and polyunsaturated intake. We usually increase it, we reduce cholesterol less than 200 milligrams daily, and we try to avoid as much as possible trans fat. Now, trans fat are really bad fats because they are the direct source of LDL cholesterol, and these include, of course, processed oils or hydrogenated oils like margarine that are common in a lot of bakeries and pastries. Basically, we're supposed to replace them with more healthy kinds of fats, including fatty fish and obviously nuts and so on. It's also important to increase the fiber intake. For dyslipidemia, we can reach levels up to 50 grams per day, and we increase the servings of vegetables and fruits in the Mediterranean diet as well as in the DASH diet. Salt reduction, this is very important because we need to have a limit for salt. Salt is basically large amount of salt is linked to excessive blood pressure and poor cardiovascular outcomes and heart diseases. So we need to limit the sodium content to 2 grams, and 2 grams per day is equivalent to 5 grams of salt, maybe which can be measured with 1 teaspoonful. And it's important not just to reduce table salt, but we also have to reduce hidden salts, such as salt in processed foods, in canned foods. Lots of sauces also are loaded with salts, as well as, unfortunately, ready-made sauces and ready-made dressings that can be added to healthy food or to healthy salads, but they end up making it less healthy or more unhealthy. So we need to limit those salt content, and we need to understand that salt substitutes are usually low sodium substitutes. So things like that are commonly known as sea salts or maybe Himalayan salt, these have identical sodium content to the table salt. So they follow the same limitations and the same recommendations, where we should not exceed sea salt or Himalayan salt more than 1 teaspoon. Low sodium salt substitutes usually are potassium salts. So continuing, we reduce the sodium, so we're going to increase the potassium, and it is well known, and research has shown that increasing potassium to greater than 3.5 grams daily actually improves and reduces blood pressure. And it is abundantly found in several food sources. You can find it in vegetables and fruits, fruits such as the bananas, also vegetables, especially leafy vegetables. And a very good source would be like arugula. Arugula has a very good ratio of potassium to sodium ratio. It has a high, but it allows a high potassium intake. And as we mentioned, that increasing potassium actually helps in reducing blood pressure. We're going to continue with sugar and fiber, and this has been probably mentioned in more details in the diabetes session, but sugar and fiber, especially sugar, for hypertension and dyslipidemia, it's important that we actually limit sugar. And what we mean here by sugar is mainly refined sugar. Yes, refined sugar that is found in sweetened beverages, that is found in processed foods, in sauces such as ketchup, for example. And when we talk about sugars, we need to mention the glycemic index of certain foods. The glycemic index is the ability of a food to increase the blood glucose. And by increasing this blood glucose, it actually increases the insulin secretion and decreases lipolysis and increases lipogenesis. So high glycemic index foods is associated, and it's linked with several bad conditions, including insulin resistance, metabolic disease syndrome, as well as fatty liver. So the food industry has always been focused on reducing fats from food, like fat-free milks, fat-free dairy, but they have failed to actually acknowledge the fact that sugars are actually the white poison that is found in our foods. So foods with high glycemic index are obviously should be avoided. You can impact, or you can affect the glycemic index of a food by how you cook the food or how you take the food. So for example, this explains how foods such as white potatoes, for example, they will have a higher glycemic index if they are baked or if they are fried compared to if they are boiled. So basically, boiling the food can actually reduce the glycemic index. That's in the case of potatoes. Also, it explains why whole wheat grains and whole wheat breads have a lower glycemic index when compared to white flour or white bread. Glycemic index can be reduced by increasing the fiber content that is taken with the food. So it's important when we're looking at food labels and when we are searching for foods to purchase from the market, that we should look at not just the sugar content, but also the fiber, sugar to fiber ratio. So the recommendations are to increase fiber intake to 25 to 29. This is for reducing blood pressure, and also in order to reduce the LDL cholesterol and dyslipidemia, it is recommended to even increase it to almost 50 grams per day. Now, fiber we know is not digestible, but it improves, as we say, as we mentioned, it improves it lowers the blood pressure and reduces the LDL cholesterol. This also explains why things like fruits are recommended to be eaten in the raw form rather in juice, because when you drink orange, let's say an orange juice or something, 1 cup of orange juice probably contains more sugars than 1 orange fruit, minus, of course, the fibers, which were actually helpful in decreasing the glycemic index of these foods. So it's important to look not just at the sugar content, but also at the fiber content. Next, we will be discussing beverages, and we will start with alcohol. Now, alcohol consumption preferably should be 0. So the 0 is basically the best, and it is shown according to research that it has the best cardiovascular outcomes. Obviously, for people that or cultures that do engage in alcohol intake, then it is considered that they have a 2-drink limit if they are males and 1-drink limit for women, and they should not binge drink. Obviously, alcohol intake is considered also a risk factor for cardiovascular disease. So it is recommended that we avoid it or limit it to those limits mentioned. Other beverages that can be consumed include, obviously, coffee and tea in moderation. So that includes 2 to 3 cups, preferably unsweetened, because, of course, if we are used to sweetening those beverages or those daily beverages, we're going to end up increasing the sugar intake in our diet. In terms of healthy juices or healthy drinks that can be incorporated in diet, most famously for hypertension or for blood pressure, is hibiscus tea. And hibiscus tea is a very underrated tea. It's actually found to reduce blood pressure, and the regular intake of hibiscus tea is actually sort of is helpful in controlling elevated blood pressure. Also, other healthy foods such as pomegranate juice and beetroot and cacao. Obviously, drinks that are sweetened, whether they're sugary drinks, sodas, all those should be avoided, and definitely energy drinks, because energy drinks are linked to increased blood pressure. Continuing with beverages, green tea, because this seems to be sort of like a very commonly used, there's a lot of marketing going towards green tea and matcha tea for increasing weight loss, increasing healthy habits. And green tea, probably in order to reduce the LDL oxidation and the LDL levels, you require almost like 4 to 5 cups of green tea in order to actually reach those benefits. There's also a lot of marketing towards matcha drinks, and that it is a power horse for fat burning and boosting your metabolism and reducing or enhancing your BMR. However, there is no significant evidence to actually back these claims. And even though they are helpful because they have antioxidants and they are known in certain amounts to decrease LDL oxidation, LDL levels, but there are even more underrated drinks such as hibiscus drinks, for example, that actually have a higher antioxidant content compared to green tea and matcha. So we will continue again with supplementation and foods. Omega-3 fatty acids, these are very important because they decrease triglycerides and decrease the bad LDL cholesterol. And it is recommended that it should be included in our diets. Omega-3 fatty acids obviously can be used as supplements, or we can take them in our foods. They are very common in mainly fatty fish such as salmons and sardines and tunas, also in different vegan forms like shea and flax seeds and avocado. And obviously these reduce cardiovascular poor outcomes, and they improve glucose metabolism. Probiotics and the gut flora. So a healthy gut flora or a healthy GIT would mean basically a healthy systemic or condition all around. So probiotics or any other terms such as prebiotics or postbiotics. These are all sources of beneficial GIT bacteria or microflora or microbiome. And basically targeting these microbiome or these healthy bacteria can help in reducing blood pressure and as well as the cholesterol and LDL levels. And obviously they can be taken either in supplement form or they can be taken from foods. So food sources that are good sources for probiotics would be yogurts or fermented foods such as kishmi and sauerkraut, pickles sometimes. So these are all sources of probiotics, and I think we should look more into basically the impact of using or enhancing our microbiome or our gut flora in order to ensure a healthier heart. So we've been discussing throughout the previous slides. We were talking about the types of foods to avoid or the types of foods that we recommend, but now we're actually mentioning how do we take these diets? How do we sort of adopt a dieting habit or a sort of a habit or a schedule for dieting or for taking this nutrition? And this comes to intermittent fasting, which is probably really well known now, especially through social media. A lot of dietitians are actually recommending intermittent fasting, and this can take several forms. So the most common form is the daily time restricted eating. Daily time restricted eating means the eating window is probably limited to 8 to 12 hours. And then after that, the rest of the hours of the 24 hours of the day, you usually are restricting your diet, you're fasting, but you're not fasting from water or you're not fasting from non-caloric beverages. You're basically just fasting from caloric foods, but you can actually drink herbal, unsweetened drinks and probably water. So this is the most common form of intermittent fasting. Additionally, we have alternate day fasting, and this means there's caloric restrictions on certain days of the week, while these restrictions are actually removed on other days of the week. There's also modified, which is caloric restrictions on certain days, such as the 5-2 diet. 5-2 diet means you're probably restricting the calories and really, really restricting for 2 days. And then for 5 days, you're basically more open to less caloric restriction. And of course, there's the religious fasting, such as Ramadan, where you fast from dusk to dawn, from dawn until dusk. And there is reverse fasting, which is basically eating from dawn to dusk and then fasting the rest of the day. So regardless of the form of intermittent fasting, they have basically different benefits. Not only do they reduce the number of calories or the caloric intake per day, but they actually have a push towards boosting metabolism, switching to ketogenic or ketone production. So the body starts basically breaking lipids into ketone bodies, and switching from glucose to ketone production. And this means basically that there is less lipogenesis, and it improves also the insulin secretion throughout the day. It also has several different benefits in glucose regulation. And the studies that have indicated the importance or the recommendations for intermittent fasting, it ranges from small to large meta-analysis. So small studies actually show that they do reduce blood pressure and they do help in weight loss. There was a meta-analysis that Ramadan fasting actually lowers blood pressure even in normotensive patients or people that have normal blood pressure. However, the large studies did not prove the superiority of intermittent fasting to caloric restriction. So the recommendation or the take-home message would be for intermittent fasting to be alongside caloric restriction in order to achieve beneficial health benefits. Now we're moving on to the next point, which is the physical activity. And physical activity involves different forms of exercise. So we have aerobic exercise, which is basically functional exercise and basically you're using your lungs. So they can be moderate or vigorous. If they're moderate exercise, it probably you can exercise moderately for 30 minutes for 5 days a week. However, it's more vigorous, such as cycling or swimming, then this could be limited to 2 to 3 times a week and probably 20 minutes per session. So this is for aerobic exercise. Additionally, other exercises include resistance exercise. And resistance exercise, usually this is limited to 2 to 3 times a week and is usually non-consecutive. And obviously this increases your muscle strength, it boosts your metabolism, and it helps overall in improving your health functions. So the recommendations for health or physical activity would be to actually incorporate them into your daily habits, incidental exercise. So for example, if you are walking to the market, or you're walking any short distance, it would be preferable that you park your car away and then do the walking, or instead of taking the elevator, you would probably take the stairs. This all increases your chances of actually moving your body. And you also need to decrease the sitting time and decrease the sedentary lifestyle. And I think that a lot of modern applications and health applications of smartwatches are actually reminders. They keep on reminding you to not sit, or to not sit for prolonged periods of time, and to actually move your body. So you need to engage in this exercise in your life, and it should be encouraged from early life, from childhood. Exercising and the importance of sports, whether it is aerobic and all kinds of different forms of sports, including structured sports, should be enhanced from a young age. And this includes basically the governments and the society should be able to encourage these, and policymakers should be encouraging these in the facilities to allow you. For example, like in certain countries, they have specific roads and tracks that are excluded only for cyclists, for example, or for running, or for jogging. Also, there are certain workplaces that actually provide the working people during working hours with a gym, so people can actually move their bodies and they can work out in these gyms during the working hours. So exercise, as we mentioned, aerobic and exercise, whether it's weight or muscle training, it could be 2 or maybe 3 but they should be non-consecutive days. When we're muscle training, it's important that we should have a weight-free period of time to enhance the benefits from these exercise. Third, we're going to be discussing the healthy weight, or maintaining optimum weight. And weight should be actually correlated with height. And this is why we use the body mass index, or BMI. BMI is basically the weight in kilograms over the height in meters squared. And greater than 25 is overweight, and greater than 30 is obese. So the target would be to reduce the BMI to be less than 25 in order to be an ideal body, or more optimum body mass index. And obviously, if you're reducing the weight, it's important that you reduce it slowly, but consistently. We also want to incorporate habits that allow or encourage the person to actually continue in this weight loss process. This weight loss process or strategy can involve different mechanisms. It can involve different strategies, including, for example, using encouragement groups, whether it's WhatsApp groups where people help each other and encourage each other to reach their healthy body weight goals. Something that is actually underrated is people basically focus on BMI, or focus on the weight rather on measurements. And it's actually important to enhance waist circumference measurements, because the waist circumference, or central obesity and abdominal obesity, is actually the major risk factor for cardiovascular diseases. So it's important to measure the waist circumference. It's important to regularly monitor your waist circumference, the decrease, to encourage or to understand whether you're reaching your goals and you're effectively reducing your weight. And there is a cutoff that the recommendation of the waist to height ratio is to be less than 0.5 in order to reduce blood pressure. Now we're going to talk about prevention of smoking and avoiding smoking and pollution. So smoking and pollution obviously is smoking. There is no direct understanding of the pathogenesis why smoking actually causes hypertension, but smoking acutely elevates the blood pressure readings. As well as smoking on its own is actually a major risk factor, of course, of cardiovascular diseases. So it's important to stop smoking, whether it's cigarettes, whether it is the first-hand smoking, second-hand smoking, whether it is e-cigarettes, these all should be avoided. Also, you should avoid air pollution exposure, and preferably when you're exercising, there should be places such as parks and greenery where people can actually walk around without being exposed to those pollutant levels. A very important challenge that has to also be overcome during smoking cessation is that a lot of people, when they do stop smoking, they actually end up gaining weight. So we need to tackle this challenge and tackle this problem because this is part of why people do not adhere to smoking cessation and stopping smoking because they're afraid of weight gain, and sometimes this weight gain can actually be detrimental to their health. So it's important to challenge and to tackle this issue. Stress also has to be reduced, and stress is linked to obviously elevated blood pressure readings. We had actually firsthand experience with stress during the pandemic and the COVID, where we were all stressing about this pandemic, and this actually had poor cardiovascular outcomes to many people. So it's important to try to find different strategies in order to reduce the stress. This can be according to everyone's preference, so breathing exercises, yoga. Daily yoga is found to obviously reduce stress and enhance or reduce blood pressure. Meditation, probably praying sometimes. Some people actually have different strategies for stress reduction, like the mandala drawings or mandala coloring. Music therapy is also found. Engagement in music therapy daily can actually reduce the blood pressure readings. So stress reduction is very important for your heart health. Now, sleep habits and sleep hygiene. The recommendations for adequate sleep habits would be ideally to sleep for 7 to 9 hours. Preferably, these 7 to 9 hours are consecutive, they're undisturbed, and they're at night. So even though nap sleeping might be useful sometimes, however, night sleeping is more consistent, aligning with our circadian rhythm. So it's important to adopt a relaxed bedtime routine. You should avoid things such as scrolling through social media before sleeping, maybe exercise, maybe anything that can actually make you less sleepy, probably drinking caffeinated drinks before sleeping. And it's important to develop a certain routine, like, for example, a relaxing bath. After a relaxing bath, maybe brush your teeth, put the sleeping mask lights off, and then go to sleep. It's important also to associate the bed with sleeping. So beds are only reserved for sleeping. They're not reserved for your work. They're not reserved for exercising. They're not reserved for anything else other than sleeping. And you try to improve these sleeping habits by following the 20-minute rule. The 20-minute rule involves when you go to sleep or when you go to bed, you tuck your bed. If you fail to sleep within 20 minutes, then you're encouraged to actually leave your bed, do something else, and then try again later. The reason for that is if you actually stay longer hours in your bed without sleeping, this associates the bed with things other than sleeping. So following the 20-minute rules can actually help with reducing your insomnia. Something that is very important and is also underdiagnosed and mistaken is obstructive sleep apnea. Obstructive sleep apnea is usually mistaken for snoring. And unfortunately, it's one of the major causes of secondary hypertension. So it's important to manage sleep apnea and breathing problems during sleep. Then we're going to discuss the digital tools. Now, this is a part where I think, like the generation, I'm not sure of the age group of most of the participants here, but assuming you're Gen Z, or I'm not sure which generation or which term do you use for yourself, but digital tools are now very common in enhancing healthcare habits. So they can be used to track your foods, your calories, not just the calories, but also the macronutrients, how much protein, how much fats that you can take. They are also useful in monitoring your movements, in monitoring your exercise, as well as your sleeping patterns. So these include, of course, things like digital watches, a lot of applications. And I think that healthcare providers, and I'm sure a lot of the participants can also be interested in developing more tools, whether they're applications or devices that can be more suitable for the culture of the country they live in. And they can encourage people to actually use these digital tools and engage in these digital tools in order to help with their good, healthy habits. So finally, we're discussing here, what is the role? So what do? We are now equipped with all this knowledge. We understand the good recommendations based on literature evidence. So what is the role of the students and what is the role of the participants in general to enhance and improve health habits in the society? So students should be encouraged to engage and consistently engage and continually engage in health awareness, whether it's in their social circle, in the university, in their school, in their health club, or even engage in other populations. It's important that they should be involved with the society in improving and enhancing health habits, and they should be always learning the different and the most novel and most newest prevention measures and recommendations in order to encourage other people to adopt these lifestyle measures. So I think this is actually what a lot of students, whether in the IVPN network and the different pharmaceutical student society, the international and Lebanese society, are actually successful in this initiation by approving and by preparing and arranging these sessions. So hats off, obviously, to all the students, and you're in the right direction in order to enhance the good health habits. So to wrap up and in conclusion, we'd just like to take from all these findings, from all these recommendations, a summary of all the pool evidence. It indicates that lifestyle changes, whether it's hypertension or dyslipidemia, they should be started from childhood and they should be maintained throughout the adulthood. It's important that you understand that these lifestyle recommendations are not just for prevention, but actually they help in the management of all stages of hypertension, all different severity stages of dyslipidemia, that we should adopt a holistic approach that involves all the different recommendations combined, such as nutrition and physical activity and reducing stress and quality sleep. These are all should be combined and encouraged for patients and people. And there's a role from not just the healthcare members, and not just the government, not just the students, but all of them collectively. They should play their role in promoting these lifestyle changes, and they should be personalized and customized according to everyone's culture, according to everyone's preference. So these are my references, and thank you for tuning in this session. It was very interesting to actually meet a lot of the speakers and the participants. And any questions?
Thank you so much, Dr. Noran, for your enlightening session on managing the role of lifestyle in managing hypertension and dyslipidemia. Your knowledge is highly appreciated. Thank you so much. Dr. Noran, is a diet and exercise enough to control a patient's hypertension? You are muted, Dr. Noran. You can't hear me.
Well, it depends on the stage of hypertension, because stages such as stage 1 and stage 2, they recommend pharmacological management along with non-pharmacological and lifestyle recommendations. So these recommendations have been found that if they are used consistently, they help in reducing blood pressure. But the reduction in blood pressure is probably moderate. If they're in stage 2, for example, reducing the blood pressure by 5 milliliters mercury will only not result in reaching the goal blood pressure. So there are certain stages of hypertension that will actually need to accompany pharmacological measurement and pharmacological treatments and medication.
Okay. And how can energy drinks affect our blood pressure levels?
Well, energy drinks, unfortunately, they have a lot of things like taurines and basically different types of proteins. These proteins, like they're discouraged, for example, athletes to use them. They can actually increase sometimes the blood pressure, or they can worsen the cardiovascular function if they are taken consistently. Obviously, not from a single use or indulging in energy drinks, but consistently drinking energy drinks is obviously not recommended. And energy drinks are also sweetened beverages, so we need to understand that we are increasing our calorie and sugar intake from these drinks.
And there's someone who's asking if high thyroid levels lead to cardiovascular disease.
Sorry?
Someone is asking if high thyroid levels lead to cardiovascular diseases.
High what levels? I'm sorry? Thyroid.
Thyroid.
Oh, high thyroid levels. Yes, thyroid toxicosis obviously increases the heart rate and and it can obviously increase your blood pressure. It can also increase your heart rate and can result eventually, if left also untreated, it can lead to cardiovascular complications. And this is the reason why people with hyperthyroidism, they usually manage also their treatments, not just by drugs that reduce thyroid levels, but also beta blockers in order to reduce the heart rate.
Okay. And there's also another person asking if eggs increase blood pressure.
No, eggs is actually a good source of fats. It has been debatable throughout time that it increases cholesterol, but actually eggs are a good source of the good cholesterol. And in fact, people are encouraged to eat eggs because eating eggs regularly in your breakfast, they've done several studies where they compared people that are actually taking eggs, and they compared them with people with the same caloric intake and do not use eggs in their diet, and instead they follow whole wheat regimens and diets and breakfasts. They found that those that actually are taking eggs help in reducing the weight, and weight reduction, even by 1 kilogram, can actually help reducing your systolic and diastolic blood pressure by 1 millimeter of mercury. And they found that studies that there were large studies that were done. They found that the moderate reduction in weight for overweight patients, even if they do not reach their optimum or their ideal body weight, it actually resulted in a decrease in blood pressure, and it helped in reducing the doses of medication that they are taking. So eggs actually are a good source of fats. This is according to the latest recommendations, and it's probably a myth that eggs are bad for your health. Is most probably just something that is marketed, by people, mainly in the cereal industry, or someone that wants to encourage those types of foods for breakfast rather than eggs.
Okay. And for our last question, does the quality and duration of sleep influence the risk and progression of hypertension?
The quality of what exactly?
The quality and duration of sleep. Does it affect or influence the risk of hypertension or progression?
Yes. Sleep. We basically, if you're not sleeping properly, you're not boosting your metabolism, so you're more likely to not lose weight. Also, sleeping, it sort of unwinds and decreases the stress levels, because when you're not sleeping, you're basically you have high cortisol levels and you have high stress levels. So basically, it can increase your blood pressure readings.
Thank you so much, Dr. Noran, for joining us today. And thank you for all the doctors for making time and effort. Ahmed, the floor is yours.
So thank you, Ruba, for your great moderation. And thank you, everyone, for attending this great webinar. So as we conclude this webinar, inshallah, on the effect of lifestyle on the management and prevention of these diseases, or the non-communicable diseases, I want to thank all the speakers and the organizers that have been involved in this great project. And also, I would love to give a special thanks to all the participants and the attendees today. And I would like to tell you that we have made an article that have been published at our LinkedIn profiles. So I will send you the link for the post, and that you can access after the session. And also the attendance certificates will be sent throughout the email that you have registered by. And thank you for having us today. And thanks to all the speakers, Dr. Nuran, Dr. Omar, Dr. Yasser, and Dr. Hagar. Thank you.
Thank you, everyone. Thank you.